Hi, my name is Alice Veksler. I am an associate professor of health and medical communication at Christopher Newport University and an ODNPH student taking the social justice class. I want to talk to you today about unresolved pain among people who are not cisgender men, which is my population of interest. And I'm going to go through the population a little bit, talk about my health disparity, which is unresolved pain, and talk about some of the sources of the disparity, and then propose a plan for resolving the issue that I think has a good chance of making a dent. So the population that I'm interested in are non-cisgender men. So that would be anyone that identifies as anything other than a cisgender male. So that would be biological women, genetic women, people with uteruses, anyone identifying as female, anyone identifying as transgender, anyone identifying as genderqueer, intersex. So quite literally anyone that is not a cisgender male would fall into my population of interest. Historically, this is a group of individuals who have been substantially marginalized, both in America, just generally, but then also within the medical community. There's a lot of discrimination, especially now, for instance, due to transphobia for individuals who are not cisgender. There's been marginalization of female health concerns historically from really the dawn of the medical establishment in the United States, when medical schools would only allow men to be physicians, just cisgender men to be physicians, and a delegitimization of the health concerns of people who have bodies that are not cisgender genetic male bodies, because much of the research in healthcare for a very long time was really done exclusively on cisgender male bodies, which means that we to this day don't know nearly as much about how other bodies function uh, as we do about cisgender male bodies. Politics has obviously been a big part of all of this. So we do need to understand that if we legislate against a particular group, then that's going to disenfranchise that group. So we see that with legislation focused on gender affirming care and reproductive rights. And so the more we say, hey, we're not going to pay attention to this particular group of people or this particular issue, the less we're going to know about it. And obviously, the more marginalized and discriminated against that group is going to feel. Now, the pain that I'm talking about as my health concern is unresolved pain. So that's going to be pain that has not been adequately treated. And it doesn't matter if it's ongoing or chronic or if it's at a snapshot in time, acute. My concern is anytime someone presents and says, hey, I'm in pain, and that pain has not been adequately addressed. So chronic pain examples would be fibromyalgia or endometriosis, or even the psychological mental pain associated with carrying gender dysphoria, or acute pain, something like the act of childbirth. There's pain at the time, but then that pain generally resolves, or IUD insertion, where that is a snapshot in time. The pain might linger for some amount of time after insertion, but it's not a chronic, unresolving ever pain. So again, the health issue itself is pain that has not been adequately treated, and I'm calling that unresolved pain. Why do we experience unresolved pain? Well, pain is subjective and we all experience it differently, but we know that based on genetic factors, based on demographics, based on access to healthcare, based on access to social support, the group that I'm focused on does end up experiencing greater unresolved pain than do cisgender men. And part of that has to do with the fact that we just haven't been paying as much attention to this population as we have to cisgender male bodies. The incidence and prevalence is really hard to estimate because there's so many different types of pain, because there's so many different ways that we can experience pain. But we know that by and large, people who are not cisgender men do report having more frequent pain. For instance, endometriosis is something that's experienced by 1 in 10 people with a uterus, and obviously 0 in 10 cisgender males experience endometriosis pain. And again, I'm not focused specifically just on uterine or gynecological pain, so there's a much larger umbrella here that we're working with, but that is an example of the fact that there are going to be some just systemic differences between cisgender men and the population I'm focused on. But we also see a greater incidence of migraine pain, a greater incidence of fibromyalgia, a greater incidence of chronic fatigue, a greater incidence of chronic pelvic pain. So kind of across the board, incidence and prevalence rates tend to be highest in this population. Not huge differences by ethnicity. We see a little bit less pain with Mexican Americans, but other than that, really no statistically significant differences in the amount of pain by racial or ethnic groups, some age differences, but really the big difference is going to be cisgender men versus my population of interest. And then we know that people who obviously are uh, more wealthy, higher socioeconomic status, access to more resources, experience less pain than people who are lower socioeconomic status and less access to adequate and equitable healthcare. So the plan that I am proposing is one that focuses on teaching physicians, teaching healthcare providers to be better about listening to women, listening to trans individuals, listening to people who are not cisgender men, and providing them with pain control, trusting them, believing them. Part of the issue that I keep coming across in my research is that people report, I go to the doctor and I tell them that they're in pain and nobody believes me, or I don't have the vocabulary for describing my pain, or my pain is dismissed as all in my mind, or like I said earlier, psychosomatic. These are all really significant problems that people in this population experience. Because of the fact that there was such a strong focus on the biomedical approach to healthcare prior to the last few decades here, um, it really is something that we need to focus on now that we have more of a socio-ecological model or a biopsychosocial model approach to healthcare delivery. So there is some work that's being done in terms of medical school reforms, like focusing more on standardized patients and problem-based learning, recognizing both the similarities and the differences in experiences of pain among cisgender men and non-cisgender men. So what I want to do is focus specifically on communication. Because ultimately, from my perspective, and like I said, I study health and medical communication. From my perspective, there's really nothing more important than communication in a doctor-patient interaction or a patient-provider interaction. So if we can teach physicians to be better communicators, and they can prompt patients to be better communicators to improve the overall outcome of the encounter and hopefully help resolve and treat some of this unresolved pain within this population. So my proposed plan is modeled after one that's been published and validated in the literature. So this is an existing program, focuses on mindfulness training to reduce biases and prejudices. The training program lasts about 8 weeks, and the trainees spend 2 hours per week engaging in these mindfulness training activities. It is a asynchronously virtual delivery of the program. Physicians who opt in would end up being credited with continuing medical education credits and potentially a stipend if funding would allow. And research shows that there's a significant reduction in bias and prejudice and an increase in empathy and trust with patients after completing this type of program. Now, in previous literature, the program wasn't focused specifically on treating unresolved pain, so that would be the modification that I'm making for my plan. I would work with the training and consulting company. Origins does a lot of training for healthcare providers and healthcare organizations. And then I would partner with previously EVMS, the Jonah Macon Brock Medical Center at Old Dominion University, because they do have a medical school so that we have access to residents and physicians, and it provides an opportunity to get access to the population of interest. And the population of interest here is not my disparity population. It's my physicians, my healthcare providers who I want to train so that they can work to reduce the disparity for for people who are not cisgender men. So my stakeholders and collaborators are going to be ODU, obviously, Origins Training and Consulting, and whatever grant agency is going to help fund this, because this can't be done for free. So probably National Institutes of Health, maybe CDC, really just depends on what grant opportunities would be available. Barriers to implementation are obviously, it takes a lot of time. People need to be interested. They need to sign up. They need to be willing to do it. People who have biases, for instance, people who are transphobic might not be receptive to this type of training, and that's obviously going to be a barrier as well. Hopefully the training would help reduce that barrier, but we do recognize that it's going to be something that needs to be overcome. And finally, cost. It's expensive to design the training. It's expensive to deliver the training. It's expensive to do proper best practices for program planning and evaluation, using proceed, precede, creating a logic model. So there's going to be a lot of time, labor, and cost that goes into designing and delivering this type of program, and also in evaluating its effectiveness in order to be able to report back to the granting agency. Now, the program is established, it is validated, it works. So I have high confidence in its efficacy. But I also do plan to follow the best practices for program planning and eval, as I just mentioned, because we need to make sure that our goals are stated at the outset. They're measurable, they're observable, we're great SMART objectives, SMART objectives, to ensure that we are going in eyes wide open, knowing exactly what we're doing and what we're hoping to accomplish on the other side. And at the end of the day, what I'm hoping to accomplish is reduction in unresolved pain for a population of individuals in America who are not identifying as cisgender men. And hopefully, by teaching physicians to be more empathetic and to be better listeners and better communicators, they will listen to this population, they will empathize with this population, and they will provide better medical care to this population, which would hopefully then function to reduce the health disparity. So I am going to click through my references here just quickly. And then if you have any questions, you're welcome to reach out to me. Those are my two email addresses and my office phone number. And I thank you so much for your time and attention.